Hello, I am Luis Nombela, interventional cardiologist from Madrid, and I am here with Guido, who has presented in the late-breaking session. Please, Guido.
Thanks a lot for the introduction. I am Guido Ascione, Italian cardiac surgeon and former research fellow at CRF. And it was my great pleasure to present here the results of the REDU-MR registry. This is a registry we have been building, now includes 10 centers across the globe with more than 600 patients. And we are trying to compare the different treatment options for failed surgical mitral valve repair. And this analysis I presented compared mitral tear and valve ring. They were about 160 mitral tear and 120 valve rings. And the main findings are basically that there were no differences in terms of survival, heart failure hospitalization, and reoperation at 5 years. But patients who underwent MTER had a lower freedom from more than moderate MR at both acutely and at 5 years. And the other interesting finding, in my opinion, is that this stratification remained the same if considering only patients who were operated for degenerative MR or only patients who were operated for functional MR. And overall, the main predictor of mortality, heart failure hospitalization, and reoperation was the discharge with more than moderate MR or more than 5 millimeters of mercury of transmitral gradient, basically highlighting that the choice between the treatment option in this context should be really done in order to obtain the best acute result, because this is what then impacts long-term outcomes.
Thank you, Guido. And looking at these findings, do you suggest, or the statement that you are a cardiac surgeon, the statement that it's better to repair than to replace, it's also translated in this population, because what we have found is that the degree of MR, or the residual degree of MR, is higher in the repair group. What do you think about this?
Yeah, that's a great question. I think that a good repair remains better than a replacement, than a valve ring, because another finding we had is that TEER patients had a better safety profile. The in-hospital complications were low, in-hospital mortality was lower in TEER, and so if we think that the valve can be treated with a good TEER, achieving an ideal acute result, I would therefore go for TEER, reserving eventually, electrosurgery and valve ring in the next step. But yeah, for sure, TEER, if we can do it in an effective way, I believe remains better than a valve ring in many occasions.
Okay, thank you. And my last question would be, how do you predict the patients that, or is there any predictive factors to know which patients they are not going to be good repair with the mitral clip?
Sure. So this was not treated in this specific analysis, but was treated in another analysis from the same registry, in which we compared TEER and REDU surgery, and this is under review. I presented this last year, and in that one we found that if the recurrent MR, so first of all, it has to be recurrent MR without any degree of stenosis, but this is kind of auto-explicatory. And then if the jet of the recurrent MR is central, so A2P2, without commissural lesions, without restriction of the leaflet motions, these actually can be treated with TEER. In most patients, only one device was used, inserted centrally, and this gave a very good result. But besides this optimal anatomy, things kind of became a little more complex, and then we need in these other anatomies a patient-centered approach in order to be sure, not to leave anything behind, because then if we do TEER in ring, the following option might not be transcatheter. I mean, there are some techniques that are being used, but it might be difficult then to do a valve ring after TEER in ring.
So thank you very much, Guido, and congratulations for these results and this challenging population, because they already have a failed procedure. So thank you very much and congratulations.
Thank you.